Welcome. I'm so glad that you all could make it today. I want to just be very conscious of the time. I know this is your lunch hour for many of you, so I don't want to run over. Just a little bit of why you're here today is because the Public Health Advisory Council will be the decision makers for funding opportunities that come down through the state in the future. So Monadnock Voices for Prevention has been tasked with educating and bringing information around substance use disorder through the continuum of care, and helping to show you as the council what a vision could look like for a resiliency and recovery-oriented system of care. So that integrated system is what we're working up to. This is the first of 4 learning sessions that came from the larger overview that we had on March 13th. And all that information came from you, from the survey that we sent out to you asking what you knew, what you wanted to know, and then how you wanted to receive that information, which was face-to-face printed materials. So today is part 1, what's the problem? And we have 2 great speakers today. We have Tim Rourke from the New Hampshire Charitable Foundation. Tim is the Substance Use Disorder and Grant-Making Strategic Initiatives Director. And then we have Rick Van Wickler, who is the Superintendent of the Cheshire County Department of Corrections. Just a couple quick housekeeping. The restrooms are over here. If you need to take a phone call, feel free to do so, but if you could step out in the hallway. And if you could save your questions to the end, there's some scrap paper at your seat if you want to write down questions so you don't forget. But we're going to have you come to the microphone because we are recording this for Cheshire TV and for a YouTube video to use for learning sessions to educate other community members, have larger forums down the road. So when the question and answer time comes, if you could go to the microphone, that would be very helpful. So I'm going to turn it over to Tim. Thank you.
Sure. Thanks. It's a pleasure to be here. So I'm Tim Rourke. I'm the Director of Substance Use Grant Making and Strategic Initiatives at the New Hampshire Charitable Foundation. We are one of the largest community foundations in the country. We make grants in a wide range of issues, but we're blessed in 1997 with the 2nd largest gift in our history from Oliver Hubbard of Walpole, New Hampshire, who left the foundation his entire estate to reduce the burden caused to the citizens of New Hampshire by alcohol, tobacco, and other drugs. We do about $3 million a year in grants, focused in policy and advocacy around substance use, as well as we're in the middle of or in year 3 of a 10-year investment in substance abuse prevention, which includes funding the regional network system, of which Polly is the staff member for this region, as well as grants in community-based treatment and community-based recovery supports, as well as my role as chair of the Governor's Commission on Substance Abuse, which I'll talk about in a little bit. I represent the foundation on that commission, and I've been serving as its chair since 2008. So what I want to do in my brief time is provide an overview of the statewide landscape around substance use. Some of you who I know were at the initial briefing of the FAC got a little bit of some of the data I'm going to share with you. This presentation, I will make this slide deck available through Polly, so don't feel like you have to scribble copious amounts of notes. We'll make sure to get it out to you. I will preface by saying that this is a slide deck I have been using with legislators as I've been speaking at legislative breakfasts and luncheons and around the state around fiscal policy issues. So there's some stuff in here that's specifically for legislators and hovers a little more in the policy arena, but you can get a sense of some of what is happening or being addressed at the state level that certainly has an influence and should influence your region's planning efforts. So we're going to also try using this thing and see how it works. And it might take some waving. So we are the healthiest state in the United States. Very typically, Annie E. Casey Foundation traditionally ranks us as one of the best states in the country to raise children. Yet when you peel back the layers of some of those indicators that give us reasons to be proud, there are some very big exceptions to that rule, and substance use is one of them. This is the National Survey on Drug Use and Health. There are 2 survey instruments that we look at in New Hampshire to assess substance use, particularly among youth. One is the Youth Risk Behavior Survey, which I will talk about in a little bit. That's a survey that's done every 2 years in schools, high schools across the state. And thankfully, many high schools in this region do it, which is wonderful because it's optional. The other survey is the National Survey on Drug Use and Health. Why we like this one, and by we, I say both the foundation and the commission, is that the national survey benchmarks New Hampshire against other states, so that we're not just looking at what's going on in our state, how, who's using, what they're using, why they're using, but how does that compare with our neighboring states to New England and our states across the country? And I will draw your attention to the fact that this is where we don't do so well. This is youth 12 to 17, 18 to 25, and 12 to 20-year-olds. So we look at substance use among youth and young adults. The vast majority of people in recovery or in active treatment will tell you that they began their use as young people. Addiction is a children's disease. It is not a disease that strikes adults who had no preconceived risk prior to that. More often than not, we see this as a children's disease. So you will notice that we are second highest in the United States for regular use of alcohol between 12 to 20-year-olds. We are second highest in terms of binge drinking. That's a lot of alcohol in a short period of time. We are also fourth highest in past year alcohol or drug dependence among 12 to 17-year-olds. What that means is that we are fourth in the United States for the percentage of young people who, based on their responses to this survey, already meet clinical criteria as having an active substance use disorder. That's huge. When we understand that we have about 100,000 people in the state of New Hampshire with a diagnosable substance use disorder, to be fourth is not something to be proud of. Now, that really looked at alcohol use, marijuana use, misuse of prescription pain relievers, and alcohol drug dependence. But I also want to talk about, I'm giving away my surprise, about opioids. Opioids that's heroin. This is also, of course, prescribed medication that is misused. But there are three numbers I want you to remember. 1, 3,275, and 300. I'm actually going to change that last number in a minute. So 1 is, if I can get there, oh, look, my surprises are gone. This survey was just updated in January, and it included a question around illicit drug use, which is heroin and misuse of prescribed opiates. We are number 1. We have the highest rates of young people reporting regular use of illicit drugs of any state in the United States. This is terrible, and it is new. 3,275, that's the number of Narcan administrations by first responders in 2014. Narcan, as many of you might be aware, is the rescue drug that is administered to someone in the middle of an opiate or heroin overdose. It takes the opiate drug that is bound to that receptor in the brain and rips it out so the person immediately goes into withdrawal. A couple of things about that number. This does not include all first responders. This is largely, and I'm looking at Polly to confirm with me, this is missing some administrations that are done by local fire departments. That information is being gathered right now, so this number is low. This also does not mean that we had 3,275 individuals, separate individuals who received Narcan. Depending on the nature of the overdose, some people need more than one dose administration in order to come out of their overdose. That is particularly true if the heroin is laced with fentanyl, street fentanyl, because fentanyl requires a much bigger hit of Narcan in order to prevent the overdose death. Which leads to the last number, which is 300. This was the number of overdose deaths in 2014 due to opiates. That is up from 216 the year before. It is in essence a tripling of overdose deaths in the last 5 years. This number this morning was updated to, I want to say, 328, because there are still open cases from 2014 that the ME is still going through. We have had anywhere from 40 to 60 overdoses already in 2015. Again, lots of investigating going, so we don't have firm numbers, but we are well on our way to eclipsing 300 in 2015 unless something changes.
So Tim, it was, as of today, you said it was like 328?
Yes, that was information I just got today.
Awesome, thank you.
Go ahead, press that button. So it's important to understand that obviously that's a big number. That's a big number in the state of New Hampshire. Certainly it might not be a big number in other states. But we were one of the first states in the country to surpass traffic fatalities in terms of opiate deaths passing traffic fatalities. That's now true nationally. More people are dying of drug overdoses than die of traffic accidents in the United States. But we were one of the states that was first. This is from a rally that was done in October by the recovery community. This is a double-sided wall. It probably, I don't know, stretched the length of this side wall over here of individuals who have died of overdoses. Some of them opiate-related, some of them alcoholism. I mean, multiple reasons and deaths over a period of time. But the loss of life to New Hampshire for this disorder is quite staggering when you consider that it is entirely treatable and for the most part preventable. So why is this happening? Why is it that we've gotten ourselves into this mess? What I would say to you is that this heroin epidemic, this opiate epidemic that we are facing is 30 years in the making. This did not come out of nowhere. This is not new. Those of us who have been in the prevention field for a long time could have told you 5 years ago, 10 years ago, that this is where we were headed. This was a foregone conclusion, and the question is why, and here is the answer. You also have this particular slide in hard copy in front of you. This is from the Substance Abuse and Mental Health Services Administration. It looks at treatment access, the availability of treatment in states for those who need it. Let's remember, the nature of this disorder very often is that people who need treatment don't think they need treatment. So there is an issue about how do we get people to seek it. But this is really about, to the extent that we know there are people who need it, how many of them could get it if every single one of them said, I want treatment now. This is a ranking of states based on treatment capacity. We are the dark red line to your left, stage right. What that means is that the only other state in the United States where you are less likely to get treatment if you are sick is Texas. We are 49th. We have the capacity to treat between 4 and 6% of the addicted population. Now, I draw your attention to the far right, which is the state with the highest access, which is Delaware. They can only treat 16%. So we have a national crisis around treatment access. It is not just our problem, but it is particularly acute in our state comparative to others. And this has been true for a long, long time. And it's all about money. New Hampshire is also second to last in per capita expenditures on substance abuse services of any kind: primary prevention, treatment, community recovery supports. We spend less as a state on issues related to substance abuse than any other state in New England by a wide margin. Although I don't have that marginal data with me, trust me, it's a wide margin. So we have huge rates of use. We have limited access to treatment for those who need it. So we begin to see the consequences spread across our state like a public health disaster. This is neonatal abstinence syndrome data. Neonatal abstinence syndrome, or NAS, these are babies who are born to opiate-addicted mothers. So the babies are, in essence, opiate-addicted at birth. Longitudinal analysis of the damage that can be caused is not clear. But we know what is clinically indicated at birth is that for a baby born with NAS, their hospital stay is 3 weeks. And the recommended course of treatment includes almost nonstop physical contact with the birth mother. So, in addition to this rise, and this only goes up to 2009, this is data from the Department of Health and Human Services. They are in the process pulling data out of Medicaid. You have to kind of go back a few years, and it takes a while to pull it out. I can guarantee for you that we are continuing an upward trajectory on this if we went into 2010 through 2015. The vast majority of these babies are on Medicaid, so the cost is borne by the state. If any of you have had a hospital stay of more than 3 days and seen the bill, you know how that expensive it is. Imagine it being 3 weeks. not just, again, for the baby, but for the parent. So we have hospitals across this state that are redesigning wings of their hospitals so that they can plan for extended stays of NAS families in their institutions in order to make sure the baby survives the withdrawal process. Huge cost to the state. Never mind, again, the potential cascade of long-term issues that could be as we look to what are the long-term implications of babies born with this syndrome. So, in addition to the lives lost and the social costs that we often think about, particularly those of us in the health and human service space in our work, when we can imagine what this does to individuals who struggle with this disorder and families, there's an economic cost here. This is a report that was commissioned by New Futures, which is an advocacy organization in this state that focuses on state-level substance abuse policy. It was done by Polycon Research, very well-respected Brian Gottlob economist on both sides of all sides of the political spectrum. The economic cost to New Hampshire in 2013, you want to just go ahead and click that once? Thank you, is $1.84 billion a year. That was in 2013, almost 3% of the gross state product. Brian, if he were here, would tell you there is nothing else in economic science that clearly attaches itself to such a huge percentage of gross state product. In Brian's assessment, there is no other economic strategy that the state of New Hampshire could deploy to grow the New Hampshire economy than to fund prevention, treatment, and recovery supports to address substance use. That is a powerful statement from an economist, that you could do whatever you want to try and create more jobs or endorse and support pathways to STEM education fields and things of that nature. But if we don't address this, you will not grow the New Hampshire economy. That's Brian's final analysis. Could you just press again? So what does that equate to? It's not just money. It's 10,000 people out of the workforce. These are employable individuals who would be job seeking or employed were it not for their addiction, or were it not for the addiction of a loved one. I talked to a business owner in Derry, very successful downtown business. She closed it a month ago because her son is struggling with a substance use disorder and she needs to dedicate more time to him. A very successful business. And she employed people. It wasn't just her that had to shut that down. I will also say that this number is low. It's an underestimate because when you do economic analysis around these kind of health issues, it is very, very difficult to get data specific to women in the workforce. So this is 10,000 men. Because this disorder knows no gender, take that number, double it, make it larger, whatever. We have a huge swath of our workforce that's currently just simply not working. We've talked to employers across the state who, it's not that they don't have jobs. They have jobs they can't fill because people can't pass a drug screen. Can you press it, please? So these costs are born in absenteeism, unfilled positions, as I talked about, certainly in the community and at the state governmental level, public safety and healthcare costs. The way I say it is if your property taxes have gone up, if your insurance premiums on your healthcare plans have gone up, it is because of addiction, because of the health costs of cleaning up what addiction does to someone when they don't get active treatment. In the property tax space, it's added law enforcement needing to be put on the street. It's expanding correction systems to manage through the justice system what's happening in our state because of this issue. Can we try that again? Thanks. So it's really the tip of an iceberg. When you read about an overdose, or you read about an arrest, or it's just one example of an absolute cascading nightmare that has fallen through our state. Again, for a disease that's largely treatable and preventable. So I want to just, so that was depressing. And now I want to dive into what is happening to address this so that you can understand contextually sort of where it is you plug in. How am I doing on time, Polly?
Well, you're almost done.
Great. 2 minutes, that's perfect. So the state has a state plan that, from the Governor's Commission that I chair. It's got 2 goals: to reduce the percentage of New Hampshire residents who are using drugs, that's the prevention side of this framework, and to increase the percentage of individuals with a disorder receiving treatment and recovery support services. Very, very simple. And quite frankly, how we get to that is very, very simple. It just seems to be complicated by this thing called politics. But this is the plan. If you have not read it, you need to read it. And the reason you need to read it is because when the commission designed this plan, we didn't design it for the commission. It's not written for me. It's not written for the agency heads on my commission. It is written for the state. So it's a long document. You don't have to read the whole thing. But depending on who you are, what stakeholder group you represent, if you're here as a parent, a healthcare professional in the medical field, a teacher, a school administrator, there are specific recommendations in this plan for your sector of the community that we believe you need to engage in order for us to meet these two goals as a state. The format of this plan also mirrors the format that the regional substance misuse coordinators like Polly are being asked to use in the development of the next iteration of the region's strategic plan to address substance abuse prevention. So everything you need to know around the kinds of activities you need to be thinking about are in this document. We have the prevention system, as I talked about. It's important to know, while it's pretty bad out there, that our prevention system is working. This is the Youth Risk Behavior Survey. It trends over time. I draw your attention to 2011 and 2013, the last two data sets. You will notice a decrease across the continuum of drugs that were tracked in use. That is so unusual that the Center for Disease Control actually called the state of New Hampshire because they thought there was an error in their data analysis. Now, with prevention, you can't prove one-to-one causality. We can't say because this thing happened, suddenly everybody stopped using. That's not how public health works, right? However, it is important to note that between the tenor of this entire data set from 2003 to 2013, in these 10 years, we have built the regional system. The system is working. In the years where we had the most significant declines in use, 2011 to 2013, and harkening back around alcohol and binge drinking, 2007 to 2009, there was another element. That was money. Between 2007 and 2009, the state received a major federal prevention grant to utilize that network system to address underage drinking. And you'll notice we did it. In 2011, the foundation began to invest about $1.5 million in the prevention system, again, through co-funding and supporting these networks along with the state. And we now have the progress that we've made to date. I say this because the system works. The structure that we put in place is paying off. But it's a Cadillac with no gasoline. So the work right now in Concord, and maybe let me see what's next. Can you just press the button, please? So I want to end with what's happening in Concord. So we know what works. We've known what works for a long time. But we've not been able to implement or execute a lot of what works because there hasn't been the resources to do it. So 3 things are on the agenda in Concord right now that can turn this around. The first is we are a control state, which means that alcohol is sold by the state of New Hampshire, and we do a darn good job of it. Last year, we took in about $680 million on the sale of alcohol. In 1997, a law was passed that created something called the Alcohol Fund, which is a dedicated fund that is designed to take 5% of those gross profits and put them into a fund to support prevention, treatment, and recovery support services in the community. It's been funded once in the year it was created in 1997. It has never been funded again. Subsequent legislatures, or sometimes the governor, has zeroed out that formula. There's a formula that gets to that dollar amount. They've zeroed it out in the budget process and then placed a general fund appropriation of some small amount into the Bureau of Drug and Alcohol Services at the state. If that fund were fully funded right now, it would be putting $8.5 million a year into the community. Right now, it puts 1.7. $650 million in profits off the sale of alcohol is nothing to smile about when we lose $1.8 billion because of the damage that alcohol and other drugs do to our state. Because let us remember, alcohol kills more people than all other drugs of use combined. We don't have a heroin problem in New Hampshire. We have a drug and alcohol problem. We can tackle heroin all we want. We won't stop the damage unless we deal with everything. So there is a request to the legislature to fully fund the alcohol fund. It was not fully funded in the governor's budget, although she came pretty close. The House took out everything she put in. And on Tuesday afternoon, I will be testifying before Senate Finance, asking them to put it all back. So that's one. The second is treatment. Beginning this year, it is illegal for private insurers to not cover addiction treatment under the Wellstone-Domenici Mental Health Parity and Addiction Equity Act. That's great, but it doesn't address the public market, and that's Medicaid. So the other two requests that are ongoing right now is to reauthorize the Health Protection Program. The Health Protection Program includes the most aggressive addiction benefit probably in the United States. We have about 10% of those currently enrolled in Medicaid health protection who are right now accessing behavioral health services. So we need that program reauthorized, because without it, individuals, if they lose their health insurance, they lose access to treatment. And we will continue to see growing wait lists of 6 weeks to 6 months for treatment. There's no other disease where we as a state would tolerate that, or as a society where we would tolerate that. Yet we have for addiction. So we're asking that the legislature reauthorize the Health Protection Program. The third is that there is still no substance abuse benefit in our existing Medicaid program. And who is eligible for our existing Medicaid program? Women and children. This is a children's disease. So we haven't asked to put a substance use disorder benefit into the existing Medicaid program. Those three things, along with communities focusing on evidence-based prevention, increasing treatment access, and creating community-based recovery supports, that is what we need in order to get this done. Anything less than that, we will spin our wheels for the next 2 years, and you will sit and just watch the deaths continue. So I'm going to stop there. I think that the work of these regions, the work of your group, is to think about how that state plan can manifest here, and to not be afraid to name your price. We are done addressing the addiction issue through goodwill and partnership. There has got to be real investment in communities to make that happen. So to the extent that you are thinking about how do we address this issue in our region, be very, very clear and unapologetic of what you cannot do because resources are not available to do it, and then engage with your legislative partners in the House and Senate to let them know. We're blessed. We have Senator Molly Kelly as a member of the commission. She's been a huge supporter of us. We have some champions in the House, but we need communities, and we need this planning process locally to be very, very clear that we can only do so much without added investment, and that we will pay without it. So with that, I'll stop for now until there are questions.
Thank you so much, Tim. We're going to do the questions and answers at the end for the last few minutes.
Great.
We're running a little bit over, but I think we'll be able to catch up. I'm just going to turn it over to Rick and let him go. The information that Tim had on her slides about the collective action, collective impact, and the YRBS, there's information about those in your binder, and the links are there as well.
Thank you, Polly. Good morning, everybody. Welcome to jail. I hope you've all brought bail money in order to get out. I appreciate the opportunity to contribute to this forum today. Usually learning about a subject helps you understand it a little bit more. And what I found is that the more that I learn about heroin addiction, the more I don't know about heroin addiction. As I research it and I talk to professionals and counselors, I also realize that the most valuable resource that we have to come to understanding addiction are addicts. And oftentimes they're missing. They're missing from the forums. They're missing from the question and answer period. They seem to be subjects of a program, subjects of a grant, but not really the subject of deep inquiry about how do they get to where they are? How do they perceive themselves getting out of it? and that's my interest. A lot of people that come here as offenders are heroin addicts. And from time to time, schedule permitting, I like to sit and I like to talk with them. And I ask them off the record very intimate questions about their life and how they got involved with using heroin. About 2 weeks ago, I sat down with 2 men and 2 women. And I'm just going to give you a sample of some of the questions that I've asked them and what the responses were. And even though this data set was only 4, it's very typical of all of the addicts that I speak with. Two of them had graduated high school. One had dropped out, and one had an associate's degree from college. Interesting enough, those 4 people, that's a very good percentage of the entire population of how it breaks out. 50% of the people here do not have a high school education. All of them are locally raised. Their first use of heroin was at the age of 18. One of them's first use was at the age of 24. They all know many people who began at an earlier age. 3 of them were under the influence of something else when they first tried it. One was not. 3 of them started by snorting it and then advancing to injection. One started by injecting. All of them responded that they liked or loved the first experience. All of them hate who they have become because of it. 2 of them said they hope to never do it again. 2 of them said they likely will. All of them report working at a local job under the influence of heroin. 3 of 4 reported driving under its influence. 2 reported having to care for small children or elderly people while under the influence. All of them have sacrificed food or living expenses to get high. None of them believe that the heroin epidemic in the community will come under control. All of them believe it will expand and get worse. None would recommend using to anybody else. All of them claim to be addicts. I wanted to know how much it costs to get high. It costs $20 to get high. I asked how long it would take for them to score if they had an opportunity to leave here today and score. The answers ranged from immediately to a long time of 15 minutes. I said, well, what happens if there's a major drug bust in the area? What happens then to the supply? Well, it forces the price of heroin to go down. And I was perplexed. It forces the price of heroin to go down because now the mid-level dealers now are competing for new markets. If your dealer is arrested, you have to find a new dealer. It affects the business of drugs. Part of the question why we're all here today, the first part of this series, is what is the problem and why do people do this? So I asked them, what's the problem? Why do people do this? Most of them answer that they do it to escape a living hell. Some of them say they first try it to be cool, peer pressure issues. All of them say that the numbing feeling solves all of life's problems. All of them have overdosed, at least once. All of them say that heroin is available in your local high school. 2 of them had family that used, 2 did not. Family interventions did not work, but rather it fueled the desire to get higher. That's a sampling of some of the questions from a data set of 4, which generally is pretty much how everybody answers those questions. I'm not going to share specific jail intake data with you today on this issue because in Series 3 here, Program 3, I'll have 2 of our employees who will share that more intimately with you. But I will tell you that heroin is the #1 drug of choice for all of the people who come into jail. I will tell you that jails can contribute to a rehabilitation process but jails are not an effective rehabilitation center. I've tried to call attention in this community, in the state, and around the world since 2007, the difference between a crime problem and a health problem. And we're getting traction. An awful lot has happened since I first brought that forward in 2007 on behalf of a major organization. We are more often around the country involving jails in our treatment, but treatment in jails is very expensive. It's also limited in its effectiveness. Treatment programs need to be long-term. We can't fix this in 30 days. We cannot fix this in 60 days or 90 days. It's a lifetime of work for most of these people. Countries that have seen beyond what we've seen, countries that have identified the difference between a crime problem and a health problem, and are going after harm reduction models and programs rather than incarceration, have experienced much greater success. And there are a lot of reasons for that. Our criminal justice system is trying to respond to this calling for treatment. We're starting to respond by saying, okay, we get it. It's a health problem in addition to being a crime problem. And so this is fueling the advancement of treatment programs in jails, of alternative sentencing efforts. Drug courts around the country are becoming popular. But it's also undeniably an expansion, as Tim said, of the criminal justice system, which is an expensive system. We've also seen in Tim's presentation that treatment time and resources for addicts, it's not brief, it's not cheap, but our state and our community resources seem to be. For jailers, we have a role conflict as we try to mingle these two things together, crime and health. For jailers, a peaceful environment results from setting and enforcing limits. For a treatment program, it's about permitting and expecting relapse and giving people second chances. Those are opposing interests for corrections professionals and for the environment. It causes great operational stress when we mix the two. And it can compromise the department's motivation on our goals. Currently in the United States, we're in what we call the crime control model, which started in the 70s. From the 1930s to the 1960s, in the United States, we had the medical model of the criminal justice system, where we believed that treatment was effective, analyzing why people did what they did was effective, and treating it appropriately. But that ended because it was expensive. And after the medical model, we went to the community model. We said most people who commit crimes that are on the books are not dangerous to other people, they're not a risk of flight. How about if we reintegrate them and rehabilitate them in the community? The 60s and 70s, we had the community model. But it ended quickly because the public didn't see this as punishment. And so here we are stuck in the crime control model, which supposes that if you incarcerate 10% of the people who commit 90% of the crime, we take care of society's problems. We now have more people incarcerated than any other country on the planet. I think where we're headed when we take the crime control model and try to disassemble it, that we're going back to a combination of a treatment model and a community model, where all opportunities of programmatic providers in the community can contribute to the health and the wellness of the people in the system. But for me, putting people in jail because they are an addict is unacceptable. It destroys that individual's life. It destroys their opportunities. It's expensive on the taxpayer. It makes very little sense. I'm going to yield some of my time today in my presentation to you because I want you to meet one of our addicts so that you can see what an addict looks like and have an opportunity to ask her some questions. Are you going to want her at the microphone?
Would you rather speak from here?
Or can she stand next to me? Can she stand next to me? Will my mic pick it up?
Yes.
Ellen, why don't you come up? Can you give Ellen a warm welcome, please? Ellen had absolutely no idea that she was going to do this today. I was talking to Polly, and I explained to Polly before our program that this is what I do. I talk to people, and I want to share some of the information. And I suggested at some point, maybe you should have one of these people here. And she said, that would be great. You have 20 minutes. Go get her. And so I went down and I asked Ellen if she would be willing to come here and meet all of you. And I imagine that this is very difficult for her. I imagine there are a whole lot of elements of emotion involved with this. In part, a little bit of embarrassment. Certainly nervous about public speaking. Nervous about what becomes of what she says today. Where does it go? Who sees it? Where does it end up? She's a very brave woman for coming here today and doing this, and we really appreciate you doing that. I'm going to tell you just a little bit about Ellen, and then I'm going to turn it over to you to ask her some questions. And believe me when I tell you that she will be honest with you. She'll tell you straight up how it is. Pretty soon, she's going to be 23 years old. She's been a heroin addict since she was 18. She is a high school graduate. She was originally arrested for unauthorized use of a vehicle and disobeying a police officer. Were you under the influence when that happened? Were you high on heroin?
No.
You were not high?
I was detoxing. I was trying to get heroin.
You were trying to get heroin. So she got arrested for that, and our system gave her probation back in 2013. Well, within 6 months, Ellen had a dirty urine. That's a violation of probation. She comes to jail, and now she's here. She's going to be leaving in about 5 or 6 days. And I asked her as we walked down the hallway to come here, or maybe it was here, you have another year of probation. Do you think that you can go another year of probation without another dirty urine? And she's not sure. She's honest. She'll be leaving here on a Suboxone treatment program. And I will leave it to some expert in the group to tell us what Suboxone can do for you. That's not my area of expertise. But with that, ladies and gentlemen, this is Ellen. And I encourage you to ask her anything that you want about her addiction, her experience, and where we go from here.
Actually, do you want me at the mic or can I ask from here? Would you go to the mic, please? Sure.
I'm just going to kind of stand here so the mic will pick you up, okay?
Hey, Ellen, I don't know if you can answer this quite yet, and it's actually a combo question. I'm Allison Welsh, Drug Court Coordinator, and Suboxone is something new that we're trying in drug court. And I guess my concern is if you have a complication with Suboxone and you end up back here, do you know what might happen? Because I don't believe, as it stands now, the jail can provide it. And have you been warned about sort of the detox side of Suboxone?
Actually, the detox of Suboxone, it can last up to a month. So when you come back here, that's definitely a problem, especially when you're taken off of it, and that's something that you're trying to continue. And it does, I think, to be on Suboxone, it takes a couple of years for you to get off of it, and only to show you what it's like to live and, you know, do normal things, compared to living this chaotic life. So being taken off of it and then having to get out and being put back on it, I think it just maybe will trip you up. I'm not really sure. I can't answer that by experience, but you know, it does. And when you don't have that, and they don't wean you off of it, I don't know, your next thing goes to what else can you get?
Yeah, I want to wish you a lot of luck with that, and I hope it's successful for you. Thank you for coming today.
Do people know what Suboxone is? So I believe Suboxone is a receptor blocker, so that when you are trying to get high, you are unable to get high. Am I correct? Am I correct?
Yes. And one of the things, as we talk about the system of care as to what effective treatment looks like, there is an abundance of evidence that, particularly for those who struggle with heroin or opiate addiction, that medically assisted treatment, whether it's Suboxone or a couple of other medications that are available, actually improve vastly outcomes of people who are trying to find and sustain recovery. One of the challenges we have in our state is that we have very few prescribers, because there are prescriber restrictions in terms of the number of clients a prescriber of some of these medications can have on their caseload. We have a lot of healthcare centers, and hopefully not in this region, but I have certainly heard it within the healthcare space, some fair resistance to taking on medically assisted treatment within the suite of the healthcare service system, because either one, we don't have a lot of doctors trained in addiction medicine, which is a workforce issue in this country, so they're not comfortable with the disorder. It's a complicated disorder. How do I make sure, because it doesn't work all by itself, Suboxone is useless unless it is administered while the individual is also getting traditional treatment and recovery support counseling they may receive. There is also some element of we don't want those people in our healthcare setting, even though those people are already in our healthcare settings. But one of the things that is part of the health protection program is the ability to reimburse for medically assisted treatment. And there are monies that are flowing right now through federally qualified health center dollars that the state has at its disposal to try and encourage and incentivize more doctors to jump on board providing and prescribing for medically assisted treatment. Treatment providers will tell you, like the Phoenix Houses of the world, there are not enough doctors. And if there's a doctor that's willing to prescribe, there are treatment centers and treatment providers that are willing to work and partner to make that happen, because it is a critical gap in our state. And the science is very clear that without it, folks who struggle with opiate addiction have a really tough time managing recovery because of the physical nature of the withdrawal, which is particularly difficult with opiates.
Hi, thanks for being here today. What do you feel that you need as far as supports as you go back into the community? You're getting your Suboxone. What other kind of supports do you feel that this community could provide to you to help you to be successful?
As a community, I mean, I'm not really quite sure how to answer that, only to the fact because there's only so much that really happens. I mean, I've gotten turned down by a rehab because I had only used for like 6 days, and you had to be using for like 2 weeks or something like that through my insurance, and that's crazy because I can't, I use once and I'm off and running. So I mean, I don't really know how to answer it as a community because I don't know if I've...
How about a job?
Definitely. And you know what? A change of surroundings. I know the geographical change doesn't really do much, but it does. I think it helps a little bit, only to the fact because you're kind of on your own, a new start. And that's what I'm trying this time. Because I've done the whole treatment. I've done treatment after treatment. I have. And I've failed. And you know what? That it's broken my hope a little bit, but being on Suboxone, I think, and going to just a new start will be good. I'm not really sure how to answer that. I'm sorry.
No, that's okay.
Another question. Would you go to the microphone, please?
Thank you for being here. I'm Susie Ann. I'm the grants manager. What would have made the difference to have prevented you from starting using in the first place? If you knew then what you know now, what would have made the difference, or what would you do differently?
Definitely maybe having someone that's done it, come and talk to me. And I mean, I was very naive. I remember like the DARE program and everything, and it was kind of like don't say no or say no, you know, and that's kind of hard when you tell me to do something. I feel like I see this a lot more with kids these days. You say no, they want to do it, you know, and it's not like that's like a command, you know. And coming from a police officer, it's like a scare tactic, you know. I like to be worked with and not looked down on, and yeah. So I guess, you know, having someone that's had experience to come in and talk to me, you know, and to show me that maybe these people, there are so many people in this world, you know, and I clung to people that I thought I would fit in and be liked because I did drugs. You know, it was like that peer pressure thing. And I guess just learning more about it and learning that there are more people in this world and you don't have to, you know, it's more of an acceptance thing for me, you know. Yeah.
Go ahead. I have one for Ellen and one for Tim. Ellen, just hearing that, it kind of makes me happy. I'm just wondering, because we've had a couple people graduate from drug court, and a couple that I think are great role models, and that they've agreed to do some like peer-to-peer support recovery. Is that something that we could connect you with in the community? Someone who's been through it who could help you and talk you through it. Is that something that you think would be a benefit?
Yeah, definitely. I mean, being with people that have gone through the same thing, I mean, it gives you hope. Like when I see one of my friends has gotten sober, he's coming up on a year now, that gives me hope, because this is a disease where, and like when he asked me if I can make it a year, I can't tell you if I can make it a year. I can't tell you if I can make it 2 days. I have to go by when I wake up and what I'm doing right now, because I can't tell you what's going to happen an hour from now. I can't. And I wish I could. I wish I could say, hey, Mom, Dad, I'm going to be good this time, you know, but I don't even want to go there. I can't get my hopes up and everyone else's hopes up. So, you know, being with someone who's been through it and giving you that hope, that's...
I appreciate your honesty. Tim, I have a question on, a couple of questions, of course. You had this slide on the past 30-day substance use, and it was great to see things going down. I just noticed one thing which was missing, and I understand the big picture of New Hampshire being affected by alcohol, substance abuse, and other drugs. Opioid use was not on that slide, and I'm assuming that trajectory would be slightly different?
For youth, not necessarily. And partially, the opiates are not, the YRBS doesn't track in that way. And admittedly, while we're number one, rates of opiate use among young people are dramatically smaller. Doesn't mitigate the problem. And the reality is the overdose deaths that we're seeing, this is adults. But the problem is, you know, it's important to remember that absent the prescription drug epidemic, the misuse of prescription drugs, which is really what catapulted us into our modern day heroin epidemic. We've had a heroin epidemic for a long time, and prior to that, the vast majority of heroin users began as recreational marijuana users. So part of it, from a preventative standpoint, is opiates are the end game. The problem is there's a whole story before that. So if all we're worried about is preventing heroin abuse, we are completely missing all the precursors. And I don't like the idea, like gateway drugs is sort of a joke. You know, there was this idea that we had, and I think we erred in our tobacco war, for lack of a better word, to suggest, well, tobacco is a gateway drug. If we stop kids from smoking, they'll stop doing everything else. What happened? We stopped kids from smoking and they drank. I could get rid of alcohol abuse tomorrow by snapping my fingers. They will use synthetic marijuana. They will use whatever is the next thing. And so I think, so part of the simple answer is it's just a function of how the survey is administered, the questions they ask, and the fact that the rates are incredibly small. Surveys are also on high schoolers. When we look at opiate trends, they tend to be in the older side, which just aren't captured in that survey. But rates of opiate use at the high school level, and I'm talking illicit heroin stuff, are minute.
One last question, I promise. You've talked about Medicaid expansion and going to testify, and I am a recipient of grants. I cannot personally lobby or testify, but I'm just wondering how you suggest enacting and mobilizing the ground troops to fight against cutting Medicaid expansion.
Sure. So new-futures.org. Part of what, they're the advocacy organization that was founded and funded by our donor. Part of the work that they do is gather names, email addresses, numbers of people who are interested in speaking out and then making sure that people are informed of when is there going. The Senate will hold a public hearing on the budget. I don't know when. I think it's been scheduled, but I don't know when. People should show up. People should not, however, wait. I mean, what I've been saying to communities is that our typical process has been the legislature does a public hearing and people come and they speak. But people come to, hundreds of people come to a public hearing and they speak about a whole wide range of issues of where the budget may fall short. That could be addiction, it could be mental health, it could be developmental disabilities. That's not enough. What people need to understand is that this afternoon, they should pick up the phone and call their senator, call Senator Kelly, call a member of the House and say, I was in this session, here's what I'm concerned about, what are you gonna do about it? So I think it needs to be ongoing and kind of incessant, but what's great about New Futures is that they have a great database where they can actually tailor notifications to people based on who their specific representatives are. Currently, right now, there's a budget issue, but I didn't talk about all the other policy issues. You know, looking at making Narcan widely available to family members, as well as first responders. There's a Good Samaritan bill that would not hold someone legally criminal if they happen to call in an ambulance because a friend of theirs is overdosed. There's a bunch of other policy pieces that are important to this that may be important to you, and they really work to tailor make so that you get an email and say, hey, this person who represents you in Concord sits on this committee and they're hearing this bill. Here's what you need to know about it. Here's what you could say, and kind of walk you through that process. But it's very, very important that people do it incessantly. It's unfortunate that we've arrived at the crisis we've arrived at, where last week we had about 600 people laying down in front of the State House when the House was voting on their version of the budget to represent the 300 plus people who died last year. It's unfortunate that it's come to that point, but unless you were living under a rock, you probably saw a picture of that event because the press covered it. And I think that level of noise is what is required from communities at this juncture if we're going to see something different out of the legislature. And from my vantage point, we're kind of out of time. And we're really out of time. I mean, you have a lovely young woman here who deserves all the access to treatment available that she can get. If she was standing here diagnosed with breast cancer, none of us would wait to make sure that she got immediately the help that she needed when she needed it. And if she was a 5-year breast cancer survivor and needed her annual checkup, there would be a place she could go to get that taken care of. And we would not tolerate the inability of someone to not access those services to manage what is a chronic illness, yet we have casually done that for this disorder for far too long. That to me is just discriminatory. And I think that's the point at which we have to, and communities have to be much more vocal, because there is ample opportunity to provide her everything she needs. And it's not there because people don't think this disease is worthy. And I think that's not how New Hampshire should work.
Thank you, Tim. And we're out of time today, so if we could give our speakers a round of applause. Thank you, Tim. Thank you, Ellen. Thank you, Rick.
Can I just give you 30 seconds?
Sure, Bill. 30 seconds.
I want to answer or give the information on the Senate hearing on the budget. The Senate Finance Committee hearing is on Tuesday, May 5th at 3 o'clock. That's in Concord in the State House. I would encourage you to come. I would encourage Ellen to come, particularly assuming you're still clean. Please come and testify. We need you. We need people there who, in fact, will testify to the reality of what's going on. Thank you.
Thank you, Bill.
Thank you, Bill.
Thank you.
Thank you so much.
Thank you so much.
So before we
Okay.
finish up today, I wanted to mention that you have the next 3 learning sessions are on in front of you. So the dates and the times, they will be here, same time. If you could RSVP, that would be really great so we can be prepared to how many people. The PowerPoint that we did on the 13th of March is also, it's been printed out and made available for you. And then we will have the YouTube link that recorded this available as soon as it's finished. And I think that is all for today. Again, thank you so much for coming.